first speaker today is Dr. Mamoon Rashid, who is a senior consultant, plastic surgeon, professor of plastic surgery, Shifa International. I would request him to please proceed to the podium. Warm welcome, please.
Assalamu alaikum, and a very good morning to all of you. It's an absolute pleasure to be here, and I'm extremely grateful to the organizers for giving me this opportunity to come here and present my work. It's also a pleasure to see so many familiar faces and friends. The session chairman, Professor Atar Naam, if you can believe it, he looks about 10 years younger to me, but we are actually class fellows way back from public school. So it's an honor to be here. Thank you so much for that. Keeping up with the Joneses is a phrase which is usually used to show that you're trying to socially keep up with your neighbors. I've used it in a slightly different context. I was trained in this country, not far from here, at St. Thomas's Hospital in the early 90s. And when I went back with a sort of resolve that I would try to do all the stuff that I'd seen here and got some experience and try to start that when I went back to Pakistan. So this is a bit of the story of really my life's work of how I have attempted to find first world solutions in the third world. How do I, right, this is a very old photograph. This is 1996, and this is the first meeting of the Pakistan Association of Plastic Surgeons, which was founded in 1995. And that's me, and really a handful of people. We were 15. Currently, our association has more than 200 members. So this is really the starting point of plastic surgery in Pakistan. Right, now, I know that there are not many plastic surgeons in the room, so let me start by this. What do plastic surgeons do? Now, her heart belongs to the cardiac surgeons, and her chest to the thoracic surgeons, and her abdomen to the general surgeons, and the pelvis is divided between the urologist and the gynecologist, and her lovely bones are treated by the orthopedic surgeons. So where do plastic surgeons come in? So this is my take on plastic surgery. We have no region of our own. So we're like the surgical nomads. We feel very comfortable going into other people's areas and doing our work there. Most people think this is what we do. We make people beautiful, and we can do that. And this is not just a temporary thing. 12 years and 3 kids later, he still has a beautiful nose. We can transform something like this into this. But modern plastic surgery has its roots in warfare, and it was the First World War where plastic surgery first gained prominence. The essence of plastic surgery is much older. We are not a specialty which is bound by regions, but we are a specialty which is bound more by techniques. Now, Harry Bunke was one of the pioneers of microvascular surgery, which is the main topic of my talk today. And he said the introduction of free flap surgery to plastic surgery can be compared to the advent of aviation to transportation. So it really was a big leap for plastic surgery. My inspiration for all of this is Professor Salim Malik, who is my mentor, and I still work together with him. And when I was coming to the UK, he said, you know, if you don't learn how to do free flaps in microvascular surgery, there's no point in coming back, because we can do the rest anyway. Microvascular surgery is a technique of anastomosing small blood vessels using a microscope or loops. You need special instrumentation, and this particular set was a going away present from my parent unit at St. Thomas's. Free flaps, it is a composite block of tissue. A good example is to think of the second toe, which you can transplant to reconstruct the thumb by using the artery and vein which supply that and re-anastomosing it up to the hand. They're also called free tissue transfers and revascularized flaps. They have enormous applications, particularly in complex defects. For simple defects, skin grafts and local flaps will do, but for large, complex defects, that is the thing to do. Starting it in a new environment was very difficult. I didn't have the proper equipment. I didn't have a team. The long operating time, 6 to 8 hours, is the average operating time. None of the anesthetists were ready to actually, let me do this. And we didn't have very good monitoring facilities. And there is this factor in free flap surgery that either it's a complete success or it's a total loss. Faisal Salim is sitting over there, and his esteemed father was one of the people who encouraged me in this. He's an anesthetist. So I started in 1994, basically with soft tissue coverage of large defects. I really had no assistance. I was begging for theater space, and I was working with an ENT microscope. We didn't have any plastic surgery microscopes at that time. And the best thing I could do was to join hand with other specialties. I could just have shown this without the backdrop, but I thought this wake up whoever was sleeping at this time. And suddenly, when I joined hand with other specialties, it gave us an opportunity to use a two-team approach, which is very important, particularly in head and neck cancer, when the ENT or the head and neck surgeon is resecting the tumor, and at the same time, you can raise your flap, and it saves a lot of space and saves a lot of time. So this is just to show you what we've been doing. This is a patient who's had a mastectomy. We've used a flap based on the deep inferior epigastric vessels. It's been transplanted. And after the nipple area reconstruction, you can see that we can pretty much get the volume and the shape absolutely right. This was a very new thing in Pakistan when we first started it. It was literally unheard of. And this is the sort of pathology that we see very frequently. This is an advanced synovial sarcoma, which is rising in the middle of the abdominal wall. This is the plan of resection. After resection, this is a huge anterolateral thigh flap. And this is after reconstruction. And this is post-operatively. You can see that there's no herniation, and the patient has a stable abdominal wall. In head and neck cancer, this is a patient who has had a hemiglossectomy. Again, a flap taken from the thigh and transplanted to reconstruct the tongue. And that's at around 8 months. And if this video will play. All right,
लास्ट ईयर मार्च में डॉक्टर साहब के पास आए थे अपने चेकअप के लिए जबान के तो दे डायग्नोज में कि ये कैंसर है डॉक्टर साहब ने मेरा ऑपरेशन किया उसके बाद प्लास्टिक सर्जरी भी की मैं अल्लाह का शुक्र है काफ़ी फील बेहतर कर रहा हूँ
बोलने में कोई मसला है
बोलने में आई डोंट फील कि कोई मुझे कोई तकलीफ है
आप पानी पी के
All right, so that will just show that even with fairly extensive intraoral and tongue resections, the patient can have very good speech and ability to swallow. Patients like these, this is a young girl who came from Chitral, specifically because of this huge vascular malformation. And underneath this, her eye was hidden. We got an MRI with contrast and a CT angio which showed this huge mass of arteriovenous malformation. She was embolized preoperatively and then resected, and we used a flap from the forearm to reconstruct the whole upper eyelid and the forehead area, and that's her after the surgery. This is a patient again with a huge vascular malformation, and this is a capillary malformation which has these fibrous nodules. He was sent by a classmate of mine who works at the ordnance factory in Wa, and he said, this chap has no problems, but he wants to get married. Can you do something for him? And so we took it all off, And we used a flap from the forearm because that skin has a good color match for the face. And that's his post-op picture. This is actually after his marriage. So the impact that this sort of surgery can have is absolutely tremendous. For the limbs, this is a patient who had a synovial sarcoma involving the first and second metacarpals after resection, and then we used a vascularized fibula, osteotomized it, and made a first and second metacarpal out of it. That's the X-ray, and you can see them. That's the bone scans showing good vascularity. And that is after completion of radiation. And this is just to show you that even with these new first and second metacarpals, something as intricate as writing his name is possible. This is a patient who had a synovial sarcoma. He's an 8-year-old kid from Afghanistan. He was offered amputation at various places. We thought that there was a potential for limb salvage here. We got together with the orthopedic surgeons, that's the X-ray and the MR, and this is the extent of surgery that he required. To reconstruct, we used the fibula, vascularized fibula based on the peroneal vessels, and that's a long plate, and the shoulder joint was basically arthrodesed, and the fibula was used to reconstruct this whole defect. And then we used the latissimus dorsi muscle because he had no functioning muscle left in the arm. So we used that muscle both as soft tissue coverage as well as to allow him to use the elbow as a functional muscle transfer. So this is 6 months later. It's very well united, and it's really unbelievable what a child can do. He doesn't have a shoulder joint, and the movement that you see is scapulothoracic movement. But he's a kid. We spent 18 hours in the theater, but 6 months later, we were ready to do it again.
2 minutes.
Okay. Right. When I was in this country, I never had an opportunity to do a penile reconstruction or be part of it or see it. But when I went back, this is one of the things that we've done a lot of. And we have one of the largest series in the world of penile reconstructions. We use a flap from the forearm, we prefabricate it, and then using a costal cartilage graft as a stiffener, we transplant it, and we anastomose the nerves. And this is the post-op result of this. This is an 8-year-old girl from Afghanistan. She lost all the fingers of her right hand. Just the thumb was left in the violence over there. This is the second toe that we've taken from her foot based on the dorsalis pedis arterial system and transplanted it to the hand. And once it's healed, there is actually very little loss in the foot. And you can see the great thing was that she could actually go back to school in Afghanistan and start writing again with her hand. Now, you keep on doing this sort of work for long and you do get problems. This is a girl who was attacked by a bear in the wake of the earthquake in 2005, and literally the bear took away the central part of the face. We reconstructed with various flaps, we fixed the facial fractures, and at the end of the day, we got it to this stage. And if I show this picture, and then I show this picture, as I have at various meetings around the world, people will literally get up and clap for me. The problem is, when this girl brings you this picture and asks you, when am I going to look like this again? And suddenly you feel so small and inadequate in whatever you're doing. And this is Paul Tessier, who said, if it's not normal, it's not enough. There is the occasional miracle which I want to show you, and this is the sort of thing which keeps us going. This is a young girl who has had 14 operations for cleft lip and palate. You can see the midfacial protrusion here. The nose is totally sagging, and she has very little definition over here. She's a brilliant girl. She's a computer engineer. and we thought we could make everything better for her. So we first expanded her mid-face, used a fibula to reconstruct the middle part of the face, and then we reconstructed her nose, and this is her, and this is her. Right. And there are no prizes for guessing who was the chief guest at the wedding. I'm just going to stop here. Thank you so much.
Okay, we can have a couple of questions from Professor, if there's anybody. Okay, Shai Latif.
Thank you, Professor Mamoon. Very interesting and intriguing as always. I just want to ask you, you mentioned the number of plastic surgeons going from that certain number, the photograph, up to 200 plus.
Yeah.
So in Pakistan, what kind of work is being done to obviously give a better understanding? Because when I was being a doctor, the first thing I remember going into medical school, the first thing and one of the most sexiest things to go into was to be a plastic surgeon. But then very few people do that. Why do you think that is?
Well, one of the problems is that all of the younger people that we're getting into training programs, once they graduate from the training programs, all they want to do is hair transplant and, Botox and stuff like that, because there's no way that financially you can compare with the revenues you can generate from something like that. And a lot of this work is, this hardcore reconstructive work. The patients are poor, you can't really charge them, and you can't really do them in small private clinics. So it's got to be a very good setup. And that's one of the problems that we are facing. We are training all our youngsters in microvascular techniques and all this work. They're exposed to them during their training, but somewhere along the line, they get distracted. And the moment they qualify, they want to be hair transplant surgeons. That's what they want to do. So, but we're at it. And if every year we find 2 or 3 people, and we can bring them back from the dark side to our side, we call it a success.